For those who have worked with Dr. Moonka personally, he delivers exquisite clinical care. He is a remarkable and very astute investigator and commands one of the sharpest acumens that I've come to work with. He'll be talking to us today about alcoholic hepatitis and liver transplantation. And the grand round will be moderated by Dr. Kimberly Brown, who's Chief of Gastroenterology and Hepatology and Associate Director of the Transplant Institute at Henry Ford Hospital. Without further ado, Dr. Moonka, the floor is yours.
Okay, does everybody see the main talk on the screen?
Great, looks good, Dilip. Thank you.
Okay, all righty. Well, first of all, I want to thank Marwan for his very generous comments. I'm a little unnerved about two things. One is I just got an email, Marwan. Is it true that there's absolutely no honorarium for this talk? Is that, did I misunderstand?
With emphasis on absolutely.
Obviously, I'm kidding. Those of you who know me know that I'm happy with all the shawarma I can eat. The second thing is a little bit more of a problem. Marwan just mentioned my talk was going to be on it's not advancing. Oh, maybe here. Just a second. Yeah, Marwan just mentioned that my talk was going to be on alcoholic hepatitis and liver transplant. I got to be honest, I thought he asked me to talk about alcoholic hepatologists and liver transplant. I was initially offended because frankly, I have been doing better of late, but you know, everybody wants to remember that 2-week period. Okay. Now we'll move to the serious part of the lecture. I will be speaking about alcoholic hepatitis and liver transplantation. I recall that I don't have a disclosure slide. I will actually be discussing some off-label treatments for alcoholic hepatitis, and my only conflict of interest is that I do enjoy the occasional cocktail, so it's hard for me to see alcohol victimized this way. Okay, we're going to start with a case, and I'm going to make it a point to finish on time. So I'll pull out my cell phone. The case is a 25-year-old woman with a history of bariatric surgery. She's been drinking a pint of vodka a day. She presents with ascites, ataxia, ophthalmoplegia, profound confusion. She has numbers that we would equate with alcoholic hepatitis, a bilirubin of 7, modest elevations of the AST and ALT, with the AST being twice the ALT, and an INR of 2.1. There's a negative evaluation for other causes of liver disease and infection. And then after starting lactulose and rifaximin, you would initiate prednisolone at 40 milligrams a day, initiate NAC, initiate parenteral thiamine, initiate liver transplant evaluation after establishing a good family support, or initiate liver transplant evaluation after 6 months of abstinence and an alcohol treatment program. Now, I designed this question because really there are people that would tell you that each and every one of these answers is correct. Initiating parenteral thiamine is key. As somebody with alcoholic liver disease, she has bad thiamine deficiency, and the clue is ophthalmoplegia, which is sine qua non for severe thiamine deficiency. So actually, this woman was in fact given parenteral thiamine with dramatic improvement in her neurologic findings. NAC, you never have to think twice about giving. We'll talk a little bit about the role of prednisolone. And then the last two options really get at the heart of the talk. So we'll just go ahead and get started. Okay. So alcohol use in the United States, it's about 5% of deaths in the U.S. are attributable to alcohol, directly or indirectly. That's about 88,000 deaths a year. Now, the 88,000 number is important because in theory, that represents the entire universe of people that you could transplant under the right circumstances. We do about 8,000 transplants a year, so you can see that that number would clearly overwhelm our ability to transplant all these individuals. 10% of patients average, 10% of individuals average more than 2 drinks a day. Men drink more than women. 5% of the US population is classified as heavy drinkers, 30 to 60 grams a day. So one of the things that we'll talk about is that there are 14 grams in a drink, and all drinks are designed by the liquor industry to be essentially the same. So we are talking about 2 to 4 drinks a day. That's 5% of the US population. 90% of these individuals will develop hepatic steatosis. 10% to a third will develop alcoholic hepatitis, and up to 20% can develop alcoholic cirrhosis. So the bottom line is it's clear that it is a major health concern in this country. Okay. One of the things that I want to do is try to feature some studies done by my colleagues. So this is a publication by Humberto Gonzalez. Stuart Gordon was the senior author, where he looked at the effect of COVID on all of this. And just so everybody knows, March of 2020 is sort of considered the cutoff for the beginning of COVID in almost all publications. And the reason for that is it was the first surge, but just as importantly, that's when we first started putting in some of the severe public health measures. So while COVID was a problem, for things like alcohol use, the public health measures were as big a problem. We shut down schools, workplaces, and that really started isolation. So what Humberto did was he looked at the number of hospitalizations on a monthly basis in the period before COVID and then in the period after COVID. And for after COVID, he looked at the months of May, June, July, August, September, presumably so he could get the publication out, but he compared it to those same months for the 4 years before COVID. And what you can see is that there is just a rapid increase in the number of admissions for alcohol-related liver disease. Now, it goes down initially just because you couldn't get people into the hospital, but then it really starts to skyrocket. Now, there are other ways you can measure the increase in alcohol consumption. So under the comments, the top line tells you that there was a 50% increase in alcohol sales in the US and a 260% increase in online sales. So COVID has taken something that was a problem and has made it worse. Now, this is a classic slide in the field of alcoholic hepatitis. And the point here is that these are the classic drinks that you might pour yourself or that you will have when you are dining out. But the key thing is that they all contain the same amount of alcohol. So the guy who makes it clear that he doesn't drink hard liquor, doesn't touch that stuff, but he's having 12 beers a day, that's just as bad as if he were having 12 heavy-duty drinks. 1.5 fluid ounces is basically what you would get from a shot glass, and 1 drink is 14 grams of alcohol. Now, the famous question is, how much do you have to drink to develop cirrhosis? It's a hard question to get at, but the answer that we've used and that has sort of stood the test of time is that for a woman, it is as low as 2 to 3 drinks a day on a consistent basis for 10 years. For a man, it is 4 to 6 drinks a day on a consistent basis for 10 years. There is a weight effect. Heavier people, taller people can tolerate more alcohol, and then women have less of the alcohol dehydrogenase, which is the main enzyme that helps metabolize alcohol. Okay, now alcoholic hepatitis, there are few entities in medicine that have as simple a definition as alcoholic hepatitis, and I try to honor that by not mucking up the definition. But the definition is very simple. It is a rapid and progressive rise in the bilirubin in the setting. It is a rapid and progressive rise in the bilirubin in the setting of heavy ongoing alcohol use after all other diagnoses have been excluded. Now, to be clear, when you go to major guidelines, there are succinct numbers. We would like the bilirubin to be greater than 3. We would like the AST to be less than 50, but just as importantly, we want it to be less than 400, ideally less than 300, because you don't get a heavy increase in the AST with alcoholic hepatitis, but you do want that AST to ALT ratio of 1.5 to 1. If the ratio is 4 to 1, it is famously said that it is alcoholic liver disease. We almost never do a biopsy on these patients. I would point out that there is this perception, even among my fellows, that alcoholic hepatitis and cirrhosis are distinct entities. That is categorically not true. 25 to 50% of patients with alcoholic hepatitis will have underlying cirrhosis. But what they've done is they've set off a new acute inflammatory process. I would also make the point that MELD is very well validated as a prognostic tool for alcoholic hepatitis. In fact, I would say it is one of the indications for which MELD works the best. Okay, so alcoholic hepatitis at its heart is a intense inflammatory and cytokine cascade that just causes processes that are extremely hard to control. The process starts with an intense steatosis of the liver, which causes a lipotoxicity, which leads to these intense inflammatory cascades. Because the inflammatory process has so many and protein causes that it is very difficult to come up with a single medication or even multiple medications that are effective against alcoholic hepatitis. Death is by infection or renal failure. Because the entity is so deadly, it is very hard to study new drugs. We don't biopsy, but if we did biopsy, this is what we might find. Now, I'm going to show you the histology with one purpose in mind and one purpose in mind only. So on the left is somebody with acute alcoholic hepatitis, and what you see is ballooning degeneration or steatosis, where you see both steatosis and ballooning degeneration of hepatocytes. You don't necessarily see a lot of inflammatory infiltrate. It's the lipids that are toxic. What you do see highlighted by the arrow is the famous Mallory-Dank-Highland body. Now, if the process continues, you can develop cirrhosis, but the cirrhosis is very distinct. The fibrosis is around the hepatocytes and around sinusoids, and you get what is famously called the chicken wire fibrosis. And the other thing is it tends to be around central veins heading towards portal veins, as opposed to the usual level of liver damage. Now, I told you I was showing you this for one reason only, and that reason is that these biopsies are absolutely indistinguishable from somebody with NASH. The toxicity is the same and the histologic findings are the same. And historically, the way we distinguished alcoholic liver disease from NASH is we simply asked the patient if they were drinking, and then that worked most of the time. That is no longer the case. So we now have what is called the phosphatidylethanol or PET test. And I have to say that aside from the antivirals for hepatitis C, in my opinion, this is one of the greatest advances in alcoholic hepatitis. And I do not mean that as a joke in any way, shape, or form. This is one of the spectacular tests of our time. Historically, we have used tests like ethyl glucuronide, which are good for 3 to 4 days. We've used ethanol levels, which are good for 12 hours. There's lots of false positives, false negatives. The phosphatidylethanol brings 3 things to the table. First of all, it measures alcohol consumption going back a month. So we famously say that the ethanol level is more of an IQ test than an alcohol test because it tells you that the patient can't even stop drinking for 24 hours. This goes back a month. The second thing is that if you use 20 nanograms per deciliter as a cutoff, there are no false positives. I've had a bunch of arguments with members of my division over the past year about this. I'm sticking with that. If the level is over 20 nanograms per deciliter, it is impossible to get that without drinking alcohol. And people have looked at mouthwash and things like that, and that's just, you can't do it. And then the final thing is between levels of 20 to 1,000, it is quantitative. It is cheap, and it has really changed hepatology. Our major objection to it is that there is a 1 to 2 week turnaround time. It is a test that's been hard for people and my fellows to wrap their head around. So I will have the fellow present a case, and they'll say, yeah, the PEth is positive, but the patient is adamant that they're not drinking, and I believe them. And I will literally walk into the room and I will say that your PEth test is consistent with somebody who has a drink in their hands at all times, and the patient will come clean. But the one thing I make clear to the patient is that we're not going to do anything unless the next PEth test is negative. And the patients shake their heads. They get it. One of the first tests that was done by a guy named Josh. One of the first studies was done by a gentleman named Josh Levitsky, who's at Northwestern. We had him come in a little while ago. And what he did was he did a study where he took all the patients they had transplanted for alcoholic liver disease, and he took all the patients where they had negative classic tests and where the patient adamantly denied that they weren't drinking alcohol, and he found 25% of those patients had a significantly positive PEth test. Okay. Now, a buddy of mine, Fred Nunez, who's a hepatologist at Penn, we trained together as fellows, called me up one day because he was distraught because he had been humiliated because he had sent a patient he had for NASH to the transplant people in his group, and they'd done a PEth test that came back at 800, and he had never heard of the PEth test, but his patient was drinking extremely heavily. So Fred is asked to write review and guideline articles for the family practice community. So the first thing he said is we've got to get this out there. And we wrote an article that we published in 2021. We did make the cover. And I will show something interesting. So here are, I can tell you that every hepatologist in the world is now married to the PEth test. But here's some guidelines that have just recently came out. So Mike Lucy and ASLD, he, for biomarkers, mentions urine and hair ethylglucuronide. PEth is buried in the middle of all of those. I don't think there's a hepatologist in the country who snipped a piece of somebody's hair and sent it for an ethylglucuronide test, but PEth follows that. The EASL guidelines literally don't mention PEth at all. And then in the guidelines that we wrote, we made it clear, consider using PEth as the first line test to differentiate heavy alcohol use. Okay, now, one of the problems with PEth is you have to be careful what you wish for. So when PEth first came out and we had patients on the list, I always said to everybody, be careful before you do a PEth test on that patient because we may be removing them off the list. Now, obviously that statement doesn't make sense. At some point you have to have a policy, and we do have a policy, which is monthly PEth testing for anybody on the list with alcoholic liver disease. But this is a very nice study done by one of my colleagues, Rania Salim. And what Rania did is she said, let's take a look at wait list removals for patients who are undergoing wait list removals or termination of evaluations for people who are being evaluated or listed for alcoholic liver disease at Henry Ford. And she said, let's compare the pre-PEth era to the post-PEth era. And what she has shown very nicely is that in the post-PEth era, a lot more evaluations are terminated, or a lot more patients are removed from the list in the pre-PEth era because we're clearly identifying that they're drinking. And that is our policy. Our policy is that you can show up drinking and we'll take a look at you. But once the evaluation has started, it is understood that the PET test will remain negative on a monthly basis, and it will remain negative while you are listed. Okay, so we'll quickly move to talking about medical therapy, and I can make this very brief because there isn't any. But I would like to talk about the issue of prednisolone, and this will be more for maybe some of the non-hepatologists in the audience. So this was the legendary study published by Willis Madry. The primary author was actually Robert Carithers. It was published in the Annals of Internal Medicine, and they randomized patients who had a high, what was called the Madry discriminant factor, which was the test that existed before MELD, and who had encephalopathy, to get either methylprednisolone or placebo, a randomized blinded study. And what you can see is that there is just a huge difference in 30-day survival between the treatment group and the placebo group. Now, the only problem was that what Madry did not emphasize in the paper at all. In fact, he didn't mention the paper at all. But what would come out later at meetings and things was that while the difference in 30-day survival was intense, there was no difference in 90-day and 1-year survival. And to some degree, he had a little bit of difficulty reproducing this in subsequent studies. So there was some controversy about whether you should use prednisolone or not. And as I like to say, it was like being a cat versus a dog person. There was no right answer. So then, and we can go through this quickly, there is one of the great studies of my time called the STOPA trial. It was a study done in England, and it was just a spectacularly simple design. They took patients with alcoholic hepatitis. You had to have a Madry discriminant factor over 32, but in fact, the mean value was 63. So all of these are patients who should have benefited from prednisone based on prior studies, and they had a simple design. So they wanted to study prednisone. They also wanted to study pentoxifylline, which is another drug that was touted to be good for alcoholic hepatitis. So there were 4 arms, 200 patients in each arm. No treatment, prednisone alone, pentoxifylline alone, or both. And the endpoints were survival at 28 days, 90 days, and 1 year. Now, let's be clear. The Madry paper had 65 patients total for both groups. This has 200 patients in each arm. It is a study out of England. And when they started to present the study, I stood up in my seat because I realized I'd finally get an answer as to whether prednisone worked or not. And here's what they found. They found that the prednisolone seemed to be a little bit better than no prednisolone at 28 days. P-value almost hit significance, though with a little massaging, you could probably get significance. This trial completely killed pentoxifylline. So at 28 days, prednisolone was clearly better. But here was the problem, okay? At 45 days, you stop seeing the benefit from prednisolone. At 90 days and 1 year, all of the lines converged. The prednisolone line is in orange. Patients start off doing better, but by the end, it is the bottom line. So based on this paper, there is really no rationale to use prednisolone. Now, I'll make a couple of additional comments. One of the problems is that if you have a patient with alcoholic hepatitis and they die, you're not happy about it. You're going to do what you can to help the patient, but deep down inside, you didn't cause them to die, unless you give them prednisolone, because one of the problems with the prednisolone group was that they had twice the infection rate. And that was the issue. There may or may not be benefit from prednisolone, but the infection rate overwhelms that. And this is only giving the drug for 28 days. So some of these issues remain an issue after the drug is stopped. Now, in a way that, so anyway, the STOPA trial was considered sort of a double knockout or double whammy for both pentoxify and corticosteroids. Now, in a way that is kind of interesting, I'm often accused of not necessarily being as academic as I should and going more on my instincts, but after the STOPA trial was presented at AASLD, and it was a huge presentation, a European, and the Europeans are really obsessed with prednisolone, a European hepatologist actually berated the guy for even doing the study because he felt it was unethical because prednisolone was a proven benefit in alcoholic hepatitis. But this is the ACG guidelines from 2018. They've seen the STOPA trial, and under number 7, patients with severe alcoholic hepatitis should be treated with corticosteroids if there are no contraindications to their use, which is infection or GI bleeding. So I just want to show that there's no reason that good data should get in the way of guidelines. Now, they are recommending using the alcoholic hepatitis differently, using something called the Lille criteria that I'm not going to get into, but it's still not a proven benefit. Okay, here are all the other drugs that have either failed or are in trials for alcoholic hepatitis. I'm not going to go through them all. I do want to, in the red box, point out a drug called DUR 928. It's an oxysterol. In theory, it can modulate lipid toxicity. It has been used in essentially an advanced phase 1 trial where it was well tolerated and seemed to have some benefit, but it was not compared to a placebo. It was compared to hysteric controls. The reason I mention that is this is a big national multi-center trial, and we are participating in this at Henry Ford, and I believe that we've already randomized some patients to the trial. If anybody's interested, the company is Direct, D-U-R-E-C-T. Their NASDAQ ticker is DURXX, and they are trading at 50 cents. So if anybody wants to take a shot at this, maybe Stuart could give you some preliminary data, and, see if we can all stay out of jail. But that is the drug that is out there. Okay, so now let's talk about alcoholic hepatitis and liver transplant. Let me see how I'm doing on time. Okay, I've got another 30 minutes. All right, so this is a 26-year-old woman who's transferred for jaundice. She is somnolent. She is oriented, but she is clearly somnolent. She and the family acknowledges that she's been averaging 12 to 16 drinks, or that she averaged 12 to 16 drinks a week in college. She's cut back, but she acknowledges that recently she's had a bunch of weddings, some parties, and she says to us, I really don't drink alcohol well, and I plan to cut back. She's got, this is an actual patient of ours, a patient's well known to our system. She's got a AST-ALT ratio of 5 to 1. She's jaundice, alk-phos 30. She's hemolyzing. We sent out a bunch of markers, and then the phosphatidylethanol was sent, but it's not going to be back for a week. The MRI shows the liver is cirrhotic. So while we might think it's alcoholic hepatitis, we would not let the diagnosis of cirrhosis dissuade us. She was interesting for our program because she had just turned 16 literally 3 days ago. And the only reason I mention that is under Obamacare, you can actually stay on your parents' insurance until your 26th birthday. So as part of caring for her, we found out that she was completely uninsured. Okay, so we'll start talking about alcoholic hepatitis and transplant. So I do want to mention something that the NIH said in 1984 about liver transplant in patients with alcohol-related liver disease. They made 2 statements, and the 2 statements, and the guys who did the consensus conference did a spectacular job, but they made 2 statements about alcohol, which ultimately are based on presumptions that just are not true in any way, shape, or form. They said patients who are judged likely to abstain from alcohol and who have established clinical indicators of fatal outcomes may be candidates for transplantation. The problem with that is there's really no good way to judge who's likely to abstain. And then the second statement they made was only a small proportion of alcoholic patients with liver disease would be expected to meet these rigorous criteria. I'm going to let you decide how true that is as we go through the talk. So in a way that's kind of interesting in transplant, centers don't always talk, or they do talk, but centers kind of all do the same thing, even though, it's not necessarily based on a criteria. And what we came up with was the rule that you had to be abstinent for 6 months and you had to do an alcohol treatment program. And 80% of centers did that. Now, it wasn't 100%, 20% of centers actually used 3 months. And then 3 centers actually had no minimum abstinence period. Didn't mean that they transplant you, but they take a look at you. I'm not going to mention their names, Miami, Medical College of Virginia, and Maryland, but they would potentially transplant you. Okay. So then we started seeing headlines and articles like this. And in the first one, we've got a, very nice looking young woman. She's blonde. She's in a convertible, and she died of alcoholic hepatitis. But I like the picture because I think the implication is that if you're a balding middle-aged guy in a Toyota Camry, there would be no issue about, letting you pass away. And then the second column is an article that was published in the Detroit News about a woman in our area who had been turned down for a transplant for alcoholic hepatitis, and UCLA was going to life flight her out to California. And this was our patient. I mean, I can talk about it because it's obviously in the news. But, this was a situation where we said no. Now, I will say that we were all concerned that the Detroit News was going to go to town on us. But in fact, they wrote a very, very nice, very, very balanced article. But you could see that momentum was changed. It was there to change our thinking. Now, this was the original study. This was a study done by a French hepatologist, Mathurin. It was published in the New England Journal in 2011, and it was the first paper, major paper done for transplant and alcoholic hepatitis. So now we're not talking about people who've been abstinent for 6 months. We are talking about people who hit the door drinking. Okay. And he knew it was going to be controversial. They vetted the patients very carefully on psychosocial grounds. And he made it clear that in this study, they looked at 236 patients and they transplanted 26. But he makes it clear that of all of their alcoholic hepatitis patients, 2% of patients were transplanted. The median level was 34. Now, the first thing that's interesting is his 1-year survival is 77%. Now, that is not going to cut it in the United States. But this was the equivalent of breaking the sound barrier. Now, there was a conference call among about 20 medical directors. I was on the call, and people were sort of saying, well, should we be doing this? And should we have guidelines? And I said I didn't want guidelines because, first of all, we were not going to be doing it. And I didn't want guidelines suggesting that we should be doing it. And I also made it clear that 77% 1-year patient graft survival will bring, UNOS and CMS to your center with handcuffs pretty quickly. And for a controversial indication, it just didn't seem to make sense. Okay, but at our heart, we are businessmen. So we weren't going to do transplants for alcoholic hepatitis then, but what happened was the number of transplants being done for hepatitis C dropped precipitously. And by the way, a large number of the transplants that are still being done for hepatitis C are being done for liver cancer. And this was obviously due to the antivirals that have just miraculously cured hepatitis C with little to no side effects. But, as one market dries up, we have to look for another market. So you can see how the increase in patients doing transplants for alcoholic hepatitis just inversely correlated with the decline in patients with hepatitis C. Okay, and this is some some data that I published with Sunji. You can see by 2019, it's not just that alcoholic liver disease is the leading indication for liver transplant, but it is growing and hepatitis C is declining. Now, again, this is all alcoholic liver disease, not just alcoholic hepatitis. And just so you know, this was a paper published a couple of months ago in Hepatology, and the headline speaks for itself. By 2040 in Canada, NAFL, and alcohol-associated liver disease, will account for almost all cirrhosis. Okay, so after the Matherin paper, the next big milestone was the Accelerate paper. And this was published in Gastroenterology in 2018. Now, this was not any kind of a forward-looking consortium. What they simply did was they identified 12 centers that were doing transplant for alcoholic hepatitis, and they gathered the data together. And they made it sound like there were all these sort of strict criteria and things, but I have my doubts. One of the monster centers for alcoholic hepatitis was Maryland, and I suspect much of this data is from Maryland. They don't break it down by center, and I can tell you Maryland had no criteria whatsoever. And they looked at 432 patients in this consortium over the past 3 to 4 years. The consortium looked at 432 patients, 155 were listed. So the first thing that I want to point out is that we've moved a far step away from the Matherin data where they transplanted 2% of patients. We're now looking at a third. 126 actually underwent liver transplant, 30%. 9 were removed from the list for improvement. Now, for me, there are a lot of fascinating things in this study that are not said. So the first thing that blows my mind is that the median MELD sodium at the time of transplant is 39. Now, for those of you who don't do liver transplant, the score only goes up to 40. So if your median MELD is 39, these patients are absolutely critically ill. Now, 8% did improve without transplant. They clearly were that group of patients who had MELDs much lower than 39. But the other thing that I find fascinating, and I didn't think about this until this weekend, and I'll tell you why I thought of this. You can't get to 39 unless your kidneys are trash. So I would have to assume that a fair number of these patients got kidney liver transplants. There is absolutely no mention of kidney liver transplant in the manuscript. And the manuscript at its heart was very pro-transplant for alcoholic hepatitis. So I think the implication was they didn't necessarily want to get the transplant kidney community riled up. Okay, now remember the median MELD sodium of 39 for another reason. And I did highlight Wisconsin in tribute to 2 of our transplant surgeons, but also for another reason. So hold that thought. So how did the patients do? They did fine. So, let me make the point, which was that when we had the 6-month abstinence period, the chemical dependency community is under the delusion that we think that the 6-month abstinence period predicts who will drink after transplant. We never thought that. And they also feel that we feel it'll predict who will do well after transplant. Well, we never thought that. What the 6-month rule meant was it was a gentleman's agreement. And the gentleman's agreement was, I won't transplant alcoholic hepatitis if you don't transplant alcoholic hepatitis, because if you do transplant alcoholic hepatitis, then I have to transplant alcoholic hepatitis. And I'll tell you what I mean in a second. So yeah, they found out that 1- and 3-year survival numbers were good, and that they found out that the risk of recidivism was relatively low. Now, the 10 and 17% numbers, that stands for sustained alcohol use, which is sustained alcohol use for over 100 days and at the time of the testing. So they're allowing themselves a little bit of wiggle room. Now, one of the other things they did was they identified parameters that would predict who would drink. And they're looking at the same patients, and they came up with what is called the SALT score for sustained alcohol use after liver transplant. And in the chart on the upper right, are some factors that stood the multivariate analysis. Drinking more than 10 drinks, 2 or more failed attempts at alcohol rehab before the current presentation, DUIs, and then history of polysubstance abuse aside from THC. Now, what was interesting is that if you tallied up the SALT score, it would tell you who would not drink. Okay, so if you had a score that was less than 5, there was a 95% chance you would not drink, but it wouldn't tell you who would drink. So if you had a score over 5, you only had a 25% chance of drinking. And if you had a score over 11, you only had a 50% chance of drinking. And I'm talking about drinking heavily. And by the way, they did show that if you drank heavily, you did not do as well in terms of 1 to 3 year patient survival. Now, when this data was presented, a couple of people made it immediately clear that 50% prediction wasn't good enough. That if there was a 50% chance that the patient wasn't going to drink, they were still going to do the transplant. Okay, there's a part of you that thinks that that's a problem for that center, but no, it's a problem for me. And I'm going to show you why. Remember I said that for these patients, the median MELD at transplant is 39? Well, as all of us in transplant know, we've changed the allocation system. So if a liver becomes available in Michigan, unless I have a patient with a MELD of 37 or higher, it is going to be offered first to a 250-mile radius and then to a 500-mile radius. So remember I mentioned Wisconsin, I asked you to remember that, but within a 500-mile radius, there is New York, there is Northwestern, I could go on and on and on. So basically, all of these centers, if they're doing alcoholic hepatitis and I'm not, they are going to suck all the livers out of our region even more than they do so already. So it was the Wild West. It was absolutely the Wild West. So Marwan's mentor, Jürgen Klintmalm, said, we've got to do something about this. He put together a consortium, a bunch there, and they came up with very, very succinct criteria. Now, nobody's beholden to these criteria, but they came up with criteria that they hope that people would adhere to. And they used a lot of the SALT data, they used additional data, but the key thing is for alcoholic hepatitis, or really just for anybody who's drinking at the time of presentation, it has to be their first presentation. So they presented a year ago with ascites and jaundice, were told to stop drinking. They did so, they recovered, and then they started drinking again. They can't go into the alcoholic hepatitis protocol. They can go into the 6 months of abstinence with a treatment program, but they should not be eligible for the alcoholic hepatitis protocol. They have to have good family support. There can't be polysubstance abuse. And they have to acknowledge that alcohol use was what destroyed their liver. So fairly straightforward things. Okay. What are some of the cons of transplanting people for alcoholic hepatitis? I've gone through some of the pros. We were concerned that would affect organ donation. It has not. There's concern that some of the criteria may discriminate on a socioeconomic basis. That hasn't really been an issue, and I'll tell you why in a few minutes in a way that's kind of interesting. Where do you draw the line? There are centers that really basically have no criteria at all. And then you do have to be careful that with alcoholic hepatitis, there's some potential for the patient to recover. Okay, but I want to make one thing clear. Transplant for alcoholic hepatitis in the setting of heavy alcohol use at the time of presentation has arrived. So this is a question from the boards. 24-year-old gentleman, history of alcohol abuse is referred because of a suspected first episode of alcohol hepatitis. His last alcohol consumption was 3 months ago. He's married. He's got a supportive family. They're using all the right buzz terms. What are the options? A minimum of 6 months of abstinence is no longer required for liver transplantation in most centers. Liver transplantation for carefully selected patients who have alcoholic hepatitis may improve survival. The bottom line is that's the right answer. So our boards are now telling us that in the right setting, alcoholic hepatitis is not a contraindication to liver transplant. All right, so we went ahead. Okay, let me just show you one more slide before I show you our Henry Ford data. So I did mention that Umberto did a very nice project or study using ICD-9 codes that showed that admissions for alcohol-associated liver disease had increased dramatically at Henry Ford. So this is a paper to the right that was published in JAMA Open Network that looked at whether this had translated into more patients being listed with alcoholic hepatitis in the COVID era and more patients being transplanted. Again, we're going to use that cutoff of March 2020. And what you can see is that waitlist additions before COVID to after for alcohol associated liver, for alcoholic hepatitis actually went from 10 to 26 a month, and transplants went from 7.7 to 21 a month. Now we're doing 800 transplants a month naturally, so the idea was that this would not necessarily have a huge impact, but it does, because very few patients who are transplanted for alcohol go into SRTR with the diagnosis of alcoholic hepatitis. So the number of transplants being done for alcoholic liver disease has almost certainly grown in the exact same way, but the numbers are going to be much larger. Now, what I will say is if you look at this bar, if you say, let's just look at February 2021, now you're looking at a 100% increase in monthly listing, and you're looking at a 410% increase in transplants being done for autoimmune hepatitis. So again, you can see that transplant for alcoholic liver disease is not going anywhere. I do want to just show you one thing. 80% of the patients were white, 9% of the patients were Hispanic, 3.8% of the patients were African American. Hold that thought. Okay. And again, I just want to mention, if you're not doing transplants for alcoholic hepatitis, you're going to see a drop in your numbers. I'm going to skip this. Okay, let me show you the Henry Ford data. What were our goals when we decided to do this? So this was it was an effort that was put together by our program, but with the understanding that we also had to move forward with transplant for alcoholic hepatitis. We decided we would use the Dallas criteria. I've given you the reference. We do pre-transplant monitoring on a monthly basis with PET levels, so we know the patient is absent while they're on the list, and then we do post-transplant monitoring. Now, one of the points that I want to make out was if you go back to the Accelerate and the SALT studies, only when we talk about the recidivism rates of 10 and 17% in 1 and 3 years, are those accurate or meaningful numbers? To some degree, not really, because they themselves concede that only 70% of the patients had any kind of laboratory monitoring, but they make it clear that it was either PET or ethyl glucuronide, but they don't tell you what percentage was which. And it's kind of like saying, well, we use PET in the honor system because ethyl glucuronide is basically the honor system. So that data did leave me a little bit queasy. Plus, they have the strict criteria for sustained alcohol use. So I'm going to show you our data. So our goals were 100% follow-up with transplant psychology. We wanted each and every patient to do an alcohol treatment program after the transplant, because inherent in the ALCAP protocol is that they're just too critically sick to do the program before the transplant. We wanted to show that we had decent patient survival, and we wanted 1 and 3 year sustained alcohol use of less than 10 and 20%. And our final goal was that neither Antu Siegel, our transplant psychologist, or Jackie Roman, our transplant social worker, submit their retirement request or their quitting request, because this has just been a huge amount of work for both of them. And I just really want to give them a shout out for not only having done the work, but really having embraced the whole project and really having taking an active interest in the care and the welfare of these patients. So how have we done? Okay, I'm just going to take a look at time. Okay, I've got 8 minutes. Okay, so we've evaluated 208 patients. It's a little bit unfair for me to put 208 patients because it's not a number that we have pinned down succinctly, but I think it's safe to say that it's somewhere between 190 and 230. Now, one of the goals that I didn't lay out was we really didn't want to find out that we were listing or transplanting too many of these patients because it is famously said that very few patients should actually meet this criteria. And in fact, of those patients, we only transplanted 14 or 6.7%. Now, the first thing that's interesting is that 7 were a liver alone, but 6 were a liver with kidney, and 1 was a liver followed by a kidney with the safety net. So the first thing is if you're going to do these, you're doing a lot of liver kidneys. So do you remember when I mentioned that in the Accelerate and SALT trials, they literally don't even mention kidney liver transplant? If you do a Google search for the word kidney or renal, good luck finding it. So again, what they probably didn't tell you was a lot of those patients got kidney livers. So have we done? All right, 100% are alive. So we've met that expectations. All of the patients followed Dr. Siegel. When I was putting together the talk, I just didn't want to hassle Antu for the data on how many had done an alcohol treatment program. So I don't have the answer to that. One of the 14 patients has had heavy and sustained ongoing alcohol use. That guy started at 2 months, and he has had a PEP level of 1,000 on a consistent basis, which means he is just hitting it hard each and every day. One patient did drink heavily, but has been abstinent for a year. And then one patient, in a way that I find kind of interesting, she's doing fine, but she's got a PEP level somewhere between 100 and 200. So just so you know, a level between 20 and 200 is consistent with moderate alcohol use. So she thinks she's got a formula for drinking after transplant. We'll see. Okay. Now, the final thing that I want to do is one of the big things is personalized medicine. And I want to give you my example of what personalized medicine might look like. So remember I told you that, I don't know if you remember, in the day in the paper in JAMA looking at transplants for alcoholic hepatitis, very few were actually African Americans. Now, your first thought is that there might be bias, but actually very few transplants are done in African Americans for NASH. African Americans, there may be some bias, but one thing that's clear is that you don't see the bias with hepatitis C. It is now appreciated that African Americans are presumably genetically protected from NASH and alcoholic liver disease. And it's not just those diseases. So one of the things that we knew in the interferon era was that African Americans did not respond to interferon well because of what we now appreciate are polymorphisms in the interferon response genes. But we also knew that the good thing for African Americans was that their liver disease from hepatitis C progressed slowly. So what I'm getting at is that there is clearly interest in identifying genetic factors that will either protect or make you more vulnerable to alcoholic liver disease. And we all know that it is famously said that 20% of patients with heavy alcohol use will never develop significant liver failure. They're more likely to die of alcohol toxicity than alcoholic liver disease. So one of the first papers to look at this involved a protein called HSD17B13. It's a protein in lipid droplets that are found in hepatocytes. Now I'm going to show you that there is a polymorphism that protects heavily against liver disease. The way this research was done, I think, was just absolutely brilliant. It was a GWAS study of a huge database, and the readout they were looking for was just abnormal liver enzymes, but they identified this gene. And there's this one particular polymorphism that's seen in about 25%. called the TA polymorphism, which protects you against liver disease. So if you have the wild type TT, you can see there's no protection against liver disease. But as you go from heterozygote to the polymorphism to homozygote, you get enormous protection against liver disease in almost all settings. Now, to be clear, this is not the polymorphism that protects African Americans. That is more likely to be something called PNAPL3, which I'm not going to get into. So I'm not saying, this is a specific polymorphism that explains the genetic differences. And by the way, Hispanics are very, very susceptible to alcoholic cirrhosis and fatty liver. So if you think that some of this is race bias, we're not applying that race bias to Hispanics. Okay, so here's my idea for personalized medicine. My idea is this. If you have a SALT score, if you're getting transplanted for alcoholic hepatitis and you have a SALT score of 1 to 4, which means that you're not going to drink after transplant, you get the TT donor liver, the one that is not protected from alcoholic liver disease, but you're not going to drink. On the other hand, if you have the SALT score of 10 to 11, which means that there is a good chance to drink, it's not a problem because we're going to give you that TATA homozygous polymorphism liver that is fully protected from your heavy drinking. So with this suggestion, with personalized medicine, we can have good outcomes for everybody. Obviously, to some degree, I'm kidding, but to some degree, I am not. I just want to end with well, first of all, let me tell you about the patient that we thought about transplanting, and let me tell you what happened to her. We did decide to go ahead and list her as part of the alcoholic hepatitis protocol, but in a way that I thought was kind of interesting. Before the transplant, we realized that she did not actually have alcoholic hepatitis. So here were her blood tests 4 days after presentation, and I am hoping that an astute hepatologist or fellow will make the correct diagnosis based on these blood tests. And the answer is she had Wilson's disease. And the clue is that she had an alkaline phosphatase of 15. And Wilson's disease famously gives a hemolytic anemia, and it gives a spectacularly low alkaline phosphatase. She had Wilson's disease. And you know what? When we finally got her PET test back, it was actually negative. It's the only time in my life that a patient has actually overestimated how much they were drinking. Okay, so what are the conclusions? Mortality for alcoholic hepatitis is high with medical therapy. Liver transplant can be performed successfully in people who have ongoing drinking with alcoholic hepatitis. The 6-month abstinence requirement is under pressure. It's not gone away completely for many patients. Recidivism remains an ongoing challenge, and the field of alcoholic hepatitis and liver transplant are continuing to resolve. I'm going to end with one final joke, and then I will take whatever questions I can. This is a famous joke at AA meetings. They like to tell this joke, which is, when they die, why do all alcoholics go to heaven? And the answer is because they've already been to hell. And the reason I tell this joke is because, we never want to lose track of the fact that these are human beings. They have a bad disease, like NASH, like many other conditions. It's not a condition over which we have complete control. And we are always interested in trying to help these individuals. But there have to be some rules, but they have to be fair rules. And on that note, I'm done. I'll be happy to take any questions. And I feel bad that we ran a little late. Sorry.
Thanks, Dilip. We have run out of time. I think Marwan wanted to say, would there be one question? There was a lot of chat going on. I'm not sure this is an easy question to answer, but it was really regarding those patients who have recidivism while being evaluated or who have been listed for transplantation. There was some discussion about whether those patients should get a second chance or whether they should be eliminated from further consideration. So maybe give your 2 cents there.
All right. Well, there's always the guidelines, and then there are the guidelines. So the rule that is published, because patients will actually ask to see the guidelines, are that if you have a positive PET during the evaluation or while you are listed, that terminates the relationship. But off the record, I will say never completely means never, though. Obviously, I could get myself into a lot of trouble for saying that.
Great. Just one more question. I know we're out of time, but getting back to your original patient, can you just make a few comments on bariatric surgery and risk of alcoholic liver disease in the setting of consumption?
Yeah, so thank you, Kim, for picking up on the fact that I specifically described a patient who had had bariatric surgery. I'm a little bit embarrassed in that I can't give succinct data, but what I can do is I can refer you to an outstanding paper from right here in River City. The lead author was Rena Salja, who reported some data from our center on rates of alcohol use after bariatric surgery. As you all know, it is a big problem. What patients will famously do is substitute one addiction for another. But she published that in Liver Transplantation, and I think that would lead you to some sync numbers. But I can tell you that it's a problem, and it's a big problem.
Great. Well, thank you, Dilip. That was really an outstanding talk. I really appreciate. It was very comprehensive. There was a lot of good discussion. This is always a topic that leads to discussion from all parties. So thank you very much, and thank you for everybody for attending.
Thank you, everyone. Have a wonderful afternoon.